Hello, everyone. My name is Logan Barshel. I'm a pharmacy intern and a pharmacy student. Today, we're going to be looking at cannabis and the treatment of chronic pain. So the objectives today, we're going to summarize available evidence regarding the therapeutic effects of cannabis in the treatment of chronic pain, explain the different forms of cannabis that have been used to relieve chronic pain, and evaluate the significance of cannabis dosage in the treatment of chronic pain. So first, we're going to look at the efficacy. First trial we have is by Wilsey et al. It was a randomized control trial, crossover in nature. And if you don't remember crossover, that just means that the placebo and the experimental group will be exposed to both treatments, and then there will be a washout period. They'll be exposed to one, and then the washout period, then they'll be exposed to the other. So there were 42 participants from a spinal cord clinic, and obviously this would be a great place to find people for chronic pain. So what they did was they allowed them to, first they took baseline data, they allowed them to vaporize 4 puffs of cannabis. And then after that, 240 minutes from baseline, they were allowed to do 4 to 8 more puffs based on how much they wanted to do. And then, so that was for the placebo, the 2.9%, and the 6.7% groups. So they utilized this neuropathic pain scale, which goes from 0 to 10, with 0 being the least amount of pain and 10 being the most. And it looks at pain qualities. Some specific qualities we have are sensitive, hot, cold, itchy, dull, and sharp. And then some spatial qualities we have are surface and deep. So baseline data was reported and then compared to after treatment. So what we have here, comparing 6.7 to 2.9% THC, we can see a statistically significant value reduction in itching pain and burning pain. Both of them were less than 0.05, which is the alpha value. And then also we see there were blood concentrations drawn, and the 90th percentile versus 10th percentile of THC COOH had reductions in deep pain and itching pain. And I think this was a good approach to take because they looked at subjective and objective data based on what the patient reported versus what blood concentrations were. And if you're not familiar with THC COOH is, it's just a breakdown product of THC to prove higher concentrations in the blood or not. So let's look at more evidence of efficacy. Here's a study by Chavez et al. This time they analyzed fibromyalgia patients, and it was parallel in nature. So that's where just the group will get only one treatment, and then that's all. So what they did was they compared olive oil as the control to cannabis, 48:1 THC to CBD. Since there's CBD present, that means that the entourage effect could help. And that's a very important aspect of THC. So each group was able to consume 1 drop daily. And then they were evaluated every 10 days for 8 weeks. They could taper that drop up based on how much they wanted to do. And in the end, cannabis was doing about 3.6 drops a day, and placebo was doing about 4.3 drops per day. They filled out the FIQ sheet every 10 days. The max score of 100 means that fibromyalgia is affecting their life more, and a lower score means that fibromyalgia is not affecting their life as much, which is what we want. So these 20 patients, they were all females, and then the results, there were only 17 that were looked at. So we can see this is exactly what we want. The FIQ scores in the beginning, cannabis versus placebo, are not statistically different with a p-value greater than 0.05. And this is important because we want them to be relatively similar before treatment. Then we can see after treatment that they're definitely statistically significantly different. Cannabis was reduced a lot more than placebo was reduced, the FIQ score. This proves cannabis efficacy, I would say. And then we look at some subgroups of the reportings, and we can see that feel good and job ability and pain were all statistically significantly reduced when comparing cannabis to placebo starting to finish. And then we can see pre versus post intervention, cannabis group only, feel good, pain, fatigue, and overall FIQ were all statistically significantly lower. And this is important because analyzing subgroups of pain reporting will tell you which kind of pain is most likely to be reduced. And it was interesting to see pain in both of them. And obviously it's important to have job ability improved because that's an important factor of daily life. Now we're going to look at the second objective, and we're going to compare cannabis forms. So this is a Whitting et al. Study. And what they did was they compared which type of cannabis could have a greater 30% reduction in pain reported. And what it turned out to be was that smoked THC produced the best results, because we can see that the confidence interval does not cross the no difference point of 1, whereas nabiximols, it does cross the no difference point of 1, although it barely does. All 8 studies combined, this also crosses the no difference point of 1. So what this grade rating would be is moderate, because it's definitely evidence that cannabis can help, but it's not the strongest evidence. And what we can see is that smoked THC in this case would have the strongest evidence for reducing pain. Let's look at the third objective now, and this would be which dosage is the best. So this was a study by Wallace et al., and they did a crossover double-blind randomized control trial. They had 16 participants, this time with diabetes, neuropathic pain. And they used spontaneous and evoked pain to test which dosage would be the best. They used a foam brush stroke, and they used a prick to the foot with a Von Frey hair filament. So whenever they did the foam brush, they dragged the brush on the dorsum of the more painful foot reported by the patient. And then with the Von Frey filament, they actually poked the dorsum of the foot until they noticed blood. And then they asked for a report in pain. So we can see this is just for spontaneous pain. The minimum pain score, as we would expect, goes downward from placebo to THC. We go 3.1, 2.6, 2.6, 2.1, we'd expect that. And we would also expect the reduction in pain to increase. You can see starting 52.8% placebo to 69.6% and 7% THC. That's what we would expect. And we can see that 4% THC mean reduction in pain had the p-value less than 0.1, which is strong evidence, but not quite as strong as 7% THC, which had a p-value of less than 0.05. Now, evoked pain, on the other hand, did not have the strongest evidence. We do tend to see general trends. If you look at with the foam brush, you can see 60% in placebo reduction in pain versus 63.8% and 1% THC, and then it kind of keeps going upward. But then we have some kind of mixed results with the Von Frey hair filament, because we see 61.2 in the placebo, 66.7 and 1%, 70.3 and 4%, but then we actually go downward in 7% THC to 65.5% reduction, which is not the strongest evidence we're looking for. We want to know if a higher dosage will help, although these general trends do support the fact that higher THC is beneficial. And then if we look at the 2017 NEST report, this is a very comprehensive look at all the THC evidence that we have out there. They did analyze chronic pain as part of the report, and it is important to note that their stance was that there's substantial evidence that THC is beneficial, or not, that cannabis is beneficial for chronic pain. So what can we conclude from this? Really, we just really need to conclude that more evidence needs to be conducted. We need to add to this growing pool of information that we have going. So some of the main takeaway points is that we have a lot of evidence that cannabis can be efficacious in the treatment of chronic pain. We need more evidence, because much of this contributing evidence, as we saw today, had either confidence intervals that crossed the no difference point, or they were moderate quality by the grade standards. And whenever we look at the next takeaway point, we can see that there may be advantages in certain dosage forms over the other, as we saw that smoked had more evidence based on the one study that we looked at compared to nabiximols. So really, we got to look at what's the best for the patient. Is it going to be smoked, vaporized, edibles? A lot of that is patient reported, but it's important to get their opinion about which one's helping them the most, and then go from there. Maybe start with the one that has the most evidence, and then try others. And then what we also found was that a higher THC cannabis may be linked to a greater reduction in chronic pain. And I put entourage effect there because it's important to also notice what other cannabinoids we have in there with the THC, because the entourage effect is so important and can play a lot of a role in whether the treatment is going to be efficacious or not. So there are my references. The hyperlinks are you can click them and then go to the sources that I used if you're interested in looking at them. Please leave any comments in the discussion thread, and thank you for watching.